Awesome. Well, sorry for the few minutes of delay here. We're having some technical difficulties getting us logged in here, but ready to go. So very excited to have one of my partners at Ohio State, Dr. Chakravarthy. He is a spine oncology expert. Really, that's his only focus. I think it's, very unique. There's not a lot of jobs around that really let someone focus on just spinal oncology, and so very rapidly becoming one of the top experts in the field. So really excited to have him. He's going to present some cases today, maybe some discussion and some time for questions and stuff too. So Dr. Chakravarthy, go for it.
Sounds good. I'm gonna share my screen. All right, you guys able to see that? Perfect.
Yep, looks good.
Awesome. Thanks, thanks, Dr. Grossbach, Dr. Vaj as well for the opportunity, and looking forward to kind of spend some time today talking a little bit about patient-centered separation surgery, really focusing on the metastatic space when we think about spine tumors. No big financial disclosures, and definitely, I think we'll have some time at the end to go through some questions and some cases as well. So I think before diving into separation surgery, really our big objectives for today are, I think NOMS is always important, and really NOMS is I'd say the backbone of managing metastatic spine disease. Two is understanding what is separation surgery, and in concept, there's a concept, but then at the same time, how do we tailor it to what the actual patient needs? And that ultimately is a bigger discussion between surgeons, radiation oncologists, and really what is the next steps in their care. And then lastly, just talking a little bit about non-surgical knowledge for surgeons and how does it impact our decision-making, kind of piggybacking off that previous point there. Let's start with the case. So this is I would say, a common case that we see here in the emergency room. So a 65-year-old female coming with about a 6-week history of back pain, some balance problems, has a known history of colorectal cancer, previously healthy, and the pain was initially pretty mild, but now it's worse. There's worse activity. It's more difficult to get out of bed. And this is the scans that you get. So here we have a sagittal MRI with contrast, as well as an axial, as well as a CT scan also, which demonstrates, a T12 pathologic fracture with significant epidural compression. And then on the CT scan, you can notice there is a bit of a pedicle fracture as well, more pronounced on the right than the left. And so as we go through this talk, I think keep these pictures in mind, and they'll kind of guide us through the talk today. So as we mentioned, really the focus is going to be on our metastatic tumors, and we're definitely seeing an increased incidence of metastatic disease. So about 20 to 30% of all cancer patients develop spine mets, and arguably there's an increased incidence just with improved imaging, improved healthcare systems, as well as improved systemic treatments. Systemic treatments are providing greater survival. However, we're seeing a differential treatment response when we think of bone disease versus systemic response. And ultimately, these patients are living longer. And so I think we're only going to see an increasing incidence of spine mets, and we need to have effective strategies to treat them. We know that it has to be done through a multidisciplinary approach. And ultimately, we're always balancing these three aspects: systemic therapy, surgery, and radiation. And the better we can balance all three, this is really the outcome that we want. Post-op, we see our patients doing things that they love, spending time with their family. The last thing we want is they're spending the last few months in the hospital, multiple wound revisions, hardware failure. And we all have these patients in our back pocket, but really the vast majority really want to avoid as much as we can. I think any talk about metastatic disease, I think needs to really talk about NOMS. And I do want to spend a little bit of time talking about NOMS. And we know NOMS to be, it's a decision-making framework. It's 4 components of neurologic, oncologic, mechanical stability, and systemic disease. And our goal is using this framework to stratify patients to systemic therapy, radiation, or surgery. And ultimately, that's going to kind of govern our decision-making process. Just very briefly, we'll kind of go through that different aspects of it. But NOMS, as we mentioned, neurologic being myelopathy or radiculopathy, the degree of spinal cord compression. O is oncologic, so radiation sensitivity. brachytherapy type of radiation, and we'll talk about the rest of it here in a moment. But I think it's important to think about how do these patients present? And I want to characterize really their presentation into three main syndromes: biologic pain, mechanical pain, and myelopathy or radiculopathy. And ultimately, the way they present, I think, has significant treatment implications. When we think of biologic pain, this is more tumor-related pain. This is I would argue, is the predominant pain syndrome we see in these patients. It's the pain that's worse at night, better when it goes through the day. And the mechanism is, it's very steroid responsive. So it's diurnal variation with endogenous steroid secretion. And so oftentimes, if you give them steroids, patient's pain does improve. Contrast that with mechanical pain. So mechanical pain oftentimes is indicative of bone pathology, so movement-related pain. And based on where it is, there's various presenting symptoms. So at the craniocervical junction, we'll see patients present with occipital neuralgia, so a searing electric pain that radiates up behind the ear. Obviously, for cervical spine, it's flexion extension. In the thoracic spine, oftentimes patients will come in and they'll say they sleep hunched over. They like to sleep in a recliner. They're more comfortable in a very kyphotic posture. And ultimately, and lastly, when it comes to lumbar pathology, oftentimes patients will present with something called mechanical radiculopathy. And so that's that searing nerve radiculopathy that follows a very specific dermatome pattern that's worse with axial loading. They'll say, positive straight leg raise. When they're up and walking, that's when things get really bad. When they're in bed, things are much more controlled. And lastly, as we know, myelopathy, contrasting myelopathy and radiculopathy are really the last aspect. So indicative of high-grade compression. And based on the amount of compression, you may see varying degrees of motor, sensory, and autonomic dysregulation. As mentioned, radiculopathy is the other aspect, and really understanding where's the pathology, where's the origin of the pathology? Is it in the foramen? Is it in the lumbar recess? Or is it out in the periphery, in the plexus, the brachial plexus, the lumbar plexus, or is it truly a peripheral nerve origin compressive pathology? In terms of evaluation, really, for all these patients, as long as they can stand, I typically do get scoliosis X-rays. I think there is some value to understanding their global alignment in terms of decision making. MRI and CT are really the mainstay, and I think of MRI as telling you what the problem is, and CT is how do you fix the problem. And so oftentimes they may come in with either a lumbar lesion or a thoracic lesion. Typically, we do image the entire spine, getting an MRI with and without contrast, as well as a CT as well. In rare instances, we do myelograms. In the emergency room evaluation, we don't typically get PET scans, but if we do have the ability to see them as an elective or through the clinic, they usually come in with PET scan as well. As we kind of jump back into NOMS, so we mentioned, and NOMS being neurologic compression, so myelopathy, radiculopathy, and the amount of epidural compression. Oftentimes, our surgical cohort is really going to be in the higher grade lesions, so grade 2s and grade 3s, where you have spinal cord compression with CSF around or really no CSF visible. Oftentimes, your lower grade compression syndromes, those get treated with radiation pretty safely. We know that when we see these patients, we're really seeing them at some point along the continuum. We don't know if they're getting worse. We don't know if they're just started to get worse or they're precipitously declining. But oftentimes, I would say as surgeons, our goal is to get these patients to the operating room in a safe fashion. If that's that night, if it's the next day, if it's in a couple days, and really using your best judgment based on the patient's neurologic presentation, patient history, but also understanding that getting them to surgery has to be done safely. So making sure they don't have a DVT, making sure they're hematologically optimized. A lot of the chemotherapy drugs that they are on can cause platelet dyscrasias. And we're obviously seeing a lot more patients now on blood thinners of various varieties. Certainly that really entails them getting there safely. Jumping back to NOMS, so O being oncologic, so much of our decision-making surgically, I think, has to rely on patients' actual pathology and understanding what the treatment effect or what the post-operative course is going to look like. We know there's two big radiation modalities, so conventional radiation versus SRS. Conventional radiation is, just for a reminder, is full field, lower dose. Typically, this is delivered in more fractions, and it's good for treating a larger field, but oftentimes it's a lower overall dose that's delivered to the tumor. SRS, or sometimes known as SBRT, is a cytotoxic, high dose, highly precise delivery usually delivered anywhere from 1 to 5 fractions. And so this allows spinal cord to be contoured, very conformal treatment, and really allows, I would say, an ablative dose to be delivered to the tumor. Numerous work was done kind of in the late 90s, 2000s, really to define what is a radiosensitive tumor and what is a radioresistant tumor. And really the primary pathology is what drives that. Things like hematologic malignancies, breast and prostate, those are your radiosensitive tumors. And your classic radioresistant tumors, and remember all this data came out in the conventional world, are your solid tumor mets, things like renal cell, non-small cell lung, sarcoma. Really, as we've evolved and been able to use SPRT with greater volume and greater success, I would argue probably there's no radio-resistant tumors. It's more so, are we able to deliver an ablative dose, and that's where maybe surgery will help facilitate that delivery. Here's a good example I like to show. This is a patient with multiple myeloma, and you can see it's a radio-sensitive tumor. It's a hematologic malignancy. And you can see just with 3 doses of radiation, how quickly the tumor melts away. And this MRI was done, I think, about a week or 2 weeks after his treatment. And so knowing that primary pathology will really help guide your decision-making process. As we continue down the NOMS pathway, M is mechanical instability. And we use the SIN score really to define what is stable, potentially unstable, and unstable. There's 6 factors, and our goal is when we're thinking about instability is, what is their fixation strategy? Is it just a kyphoplasty? Is it percutaneous instrumentation? Or do they truly need an open separation surgery with anterior column, posterior column, etc.? It has 6 components, so things like location, pain, bony lesion, alignment, vertebral body, and posterior elements. And again, I think a lot of this has to be, in terms of a guiding principle as to, what are our goals of surgery? Here's just a quick example of how we use the SIN score. So this is a patient with a T9 or T11 pathologic fracture with mechanical back pain. It's a junction location with pain. It is in the potentially unstable category, but he had no epidural disease, no spinal cord compression, truly just a vertebral body-based lesion. And this was somebody that we thought was pretty amenable to a kyphoplasty to help treat his pain. The patient did well. And that data comes out of the CAFE study. So this was published in 2011 in the Lancet Oncology journal. It was looking at patients with pathologic fractures, cancer-related pain that got kyphoplasty versus non-surgical management, and it allowed for a crossover. Importantly, there was improvements in back pain, back specific function, and quality of life, both 1 month after kypho, but also lasted up to 12 months post procedure. So I think in well-selected patients, this definitely has good value. I think sacral metastatic disease is really is a challenging, I argue, is a challenging pathology to treat. It is rare. I think it oftentimes does signify advanced disease. And oftentimes patients will present with things like pain, pathologic fracture, nerve root compression. Oftentimes they complain of mechanical pain and difficulty with ambulation. And then often bowel and bladder incontinence or bowel and bladder urgency syndromes. The challenges, and I would say often, we do use radiation to treat this. There's various series out there looking at surgery. There's even, I think this is, I think, out of the MSK group looking at doing a sacroplasty where you actually instill cement into the bone or defected area of the sacrum. 25 cases, 31 sacroplasties, a good outcome, good improvement in pain. And this is kind of this is a picture from their manuscript showing that it's safe, it can be done safely, and it does have some value. But I think I do want to highlight this manuscript. So this came out of this was done in 2019. It was a review of literature looking at surgery plus radiation versus radiation alone. Really looking at, is there any improvement in healthcare quality of life and pain following both treatments? And arguably, when we compare these two groups for metastatic disease, really there's not much difference. And I think similarly, I would say I probably think of the majority of these cases as radiation primarily, and surgery really in rare instances, things like insufficiency fractures, and in some nuanced areas. And here's a case example, I think, to illustrate that. So this was a 68-year-old gentleman with prostate cancer. He was diagnosed back in 2005. In April 2023, he was initially identified with a sacrometastatic lesion. Prostate cancer, being fairly radiosensitive disease, was initially treated with radiation. And and he did well. His pain got better, and actually, there was good hope that there was any good control. He eventually actually presented to my clinic complaining of gluteal and hip pain, and a lot of mechanical back pain that was limiting his ambulation. He was noticing he wasn't able to walk as long distances due to pain, and he also was having some episodic urinary incontinence and dribbling. Here are his pre-op films, and so you can see he has a very large presacral lesion that was really involving almost S2 down to S4, S5. We actually did a amino acid PET scan. Given that it had already been radiated, we even did a biopsy, which confirmed prostate pathology with central necrosis. You can see on the PET scan, this is amino acid PET showing some peripheral enhancements suggestive of maybe active disease. Here in metastatic disease, oftentimes post-radiation, we use perfusion MRI a lot. And you can see on the perfusion MRI, for the most part, this is a pretty cold lesion. But on subsequent scans, this was getting larger, and due to symptoms, I think after numerous discussions, we had numerous kind of things on our agenda in terms of what should we do. Is he a candidate for more radiation? Is now the time to consider surgery? What are our goals? What symptoms are we looking to improve? How's the systemic disease status? And then ultimately, and should we, abort any sort of surgical treatment and consider palliative care? And so this truly, I think, took, multiple discussions, myself, the radiation oncologist, the medical oncologist, really to understand each aspect of patient's care. In the end, we did feel that, we were not in a position to be able to give more radiation. He had very limited systemic disease burden, and he's a pretty high functioning individual. And so there was good hope that, despite his bowel bladder decline, probably that would occur despite the natural history. And so, surgery was thought that it was recommended in this case, and we proceeded. So we ended up doing a posterior approach, L4 to pelvis fixation with tumor debulking. Being a metastatic case, I didn't think doing an en bloc really made sense. We did have plastic surgery close the wound. He had been previously radiated, and given its location, wanted to really minimize all morbidity. But you can see, post-operatively, he had no improvement in bowel bladder. He did have improvement in mechanical back pain, and he was ultimately able to ambulate better, and he felt his pain was better. Given that we did more debulking, he did receive another dose of SBRT. So the first time was conventional, then he got SBRT for this one. But unfortunately, he ended up undergoing 5 wound washouts over 3 months, and he had multiple readmissions. Now he's back home, and he's doing well, almost 6 to 8 months after his first surgery. And so I think mainly I want to use this case to highlight, I think there's a role for surgery, but I think it has to be very selective, and given its location, I think the morbidity is high, and ultimately we have to figure out how does it play into the bigger setting of their systemic disease burden. As we jump back to NOMS, so as we come down to the prediction realm, so as to systemic disease, as you mentioned, and when we think of systemic disease, there have been numerous groups around the world that have tried to figure out good prognostic scores that have adequately helped. These are just examples of them over, say, in the past 2 decades, including the Tokahashi, the Tomita, the Bauer score. Those have really matriculated into these. I would say these are 2 mainstay scores. So the Sorg nomogram as well as the New England Spine Metastatic score. Key things to take away from both of these is that it's a combination of amount of mets, location, hematologic factors, things like albumin, hemoglobin, as well as ambulatory status. And so I use these routinely in my practice, especially in the outpatient setting, just trying to figure out what sort of elective surgery makes the most sense. But also when they do come into the emergency room, how best to advise patients in the postoperative period. This is an interesting study. So this was work done out of MGH, where they took the New England Spine Metastatic score, but then also added breast cancer hormone receptor status. We know that in each tumor paradigm, so renal cell, non-small cell lung, breast, etc., there's varying degrees of receptor status that have favorable as well as poor response to treatment. And so you can see here clearly patients that had low New England Spine Metastatic score with hormone receptor positivity tended to have a better overall survival versus those that were triple negative breast, had high New England Spine Metastatic scores, really had poor overall survival after surgery. I think this is really going to be the way that we have to continue to think about these tumors, knowing that not all breast cancer is the same, not all renal cell cancer is the same, and really personalizing that approach to each patient. This is work that we did when I was in residency, but taking it one step further, trying to understand, are there genomic predilections for the spine? This is a series of 131 patients with breast cancer, noting that the PIK3 mutation was the most common gene mutation in patients undergoing surgery. And so can we use data like this to figure out targetable mutations to maybe minimize spine disease burden? Really, I think would be exciting work here. As we simplify NOMS, we can say patients with low-grade spinal cord compression with radiosensitive tumors often get conventional radiation. Patients with high-grade tumors, radio-resistant pathologies, oftentimes those patients are getting surgery with SRS. Just kind of let everybody catch their breath. So here's a nice picture of an elephant riding a scooter. So before we enter the next foray, so as mentioned, we talked a lot about NOMS, and I think before we enter the surgical world, I want to talk a little bit about SRS. I think as a spine surgeon, especially seeing metastatic disease, whether it's with volume or it's infrequently, I think it's still important to understand what are the modalities these patients are going to experience, and how best can you then tailor your surgical approach to fit those modalities. As we have continued to adopt SRS, we've really gotten away from en bloc resection for metastatic disease. This is a case of a T10 solitary met. Years ago, we'd be doing en bloc resection with high morbidity and high blood loss. Now we're able to treat those patients just as effectively with outpatient surgery and no blood loss. And really, this has really been incorporated into the paradigm and will continue to have a larger role for our patients. In terms of highlighting the SRS data, so this is a manuscript of MSK looking at the role of SRS in radio-resistant tumors primarily. So 811 tumors, 82% radio-resistant. And really, when we look at the data, we're able to see that we're getting good tumor control at 4 years. And so clearly this works. Really, the most important thing is, can we get effective dose in? We are able to add checkpoint blockade immunotherapy to SRS or SPRT, and so we're able to take advantage of something called the episcopal effect, where we can actually induce basically the body's own immune response to you could say supercharged to fight the oncologic disease and fight the systemic disease. But ultimately, what we do is we get the benefit of treating a local site, but then having a distant response. So this is a manuscript of a New England Journal showing treatment of SRS distally would actually improve the response in the lung. So I think taking advantage of the episcopal effect is powerful. Obviously, we know that all patients with metastatic disease aren't the same. It's the number of mets, and you can define that as oligometastatic as a definition where patients have 1 to 5 metastatic sites. And there's good data now. There's 2 big studies that have come out. One is the Sabre Comet trial, and next is the PISA trial, both demonstrating good benefit in being aggressive in patients with oligometastatic disease. So typically patients with 1 to 5 mets, whether it's surgery, whether it's radiosurgery, knowing that there's a overall survival benefit in treating those patients, but then also giving them an ablative dose. So not only are we being aggressive, but then also being aggressive with our actual treatment ability. With all good things, we know that there's concerns. So understanding the organs at risk and the toxicity is very important. The spinal cord typically has a Dmax of about 14 gray, and you can see the nerve root plexus is 24 gray. And so that's why oftentimes the lumbar spine and the sacrum, we're able to deliver a much higher dose with much more safety. But we are limited in the spinal cord at the spinal cord level. As good as SRS is, I think there is some challenges. Given the higher dose, given the more focal dose, there's a higher risk of fractures. We know that there's about a 2-fold increased risk of fractures with SRS. Oftentimes, patients that we somewhat shy away maybe from SRS or we consider surgery up front are those with pre-existing fractures, lytic tumors, maybe present with a spine deformity. So now I want to spend kind of the last half hour, 20 minutes, really talking about separation surgery. And really, what are our goals? How do we think about it? And how can we continue to improve on it? And so our goals, and when it comes to metastatic disease or separation surgery, I would say, are to preserve neurologic function, give local tumor control, provide mechanical stability, pain relief, but then improve overall quality of life. Oftentimes, I tell my residents a lot, as surgeons, we don't treat tumor biology, especially in the metastatic space. The sooner we can accept that, the sooner I think we can take care of patients better. I think we're great at treating spinal cord compression. We're great at treating instability, but we don't treat tumor biology. And I think we need to make sure that we don't serve as barriers to patients getting to the next phase of their care. Here's a good case. So a 66-year-old woman with papillary thyroid cancer, high-grade compression. And so if you follow the NOMS paradigm, this is a patient that would get SRS or separation surgery followed by SRS. And where does the data come from? So Patchell in 2005 published his landmark paper demonstrating the value of surgery with radiation compared to radiation alone. And then he saw improvement in overall ambulation, less narcotic use, but also increased survival. And so this definitely led to an explosion of surgical techniques for metastatic disease. And over the next decade or so, those techniques continue to get refined with numerous works, both Patchell, this was actually out of Germany, a Kleeflam's group looking at 101 patients with 106 METs, and really understanding that what predicts recurrence. As great as surgeons we know that with this study that tumor histology is what predicts recurrence. And it's independent of how much we take out, but what the actual histology is. These manuscripts and numerous other manuscripts at the time came out with a really landmark recommendation from AO, stating that patients with high-grade compression due to solid tumor malignancy, they're candidates for surgical decompression and stabilization, followed by radiation. And I would argue this conversation continues to evolve, understanding what is the kind of surgery and what kind of radiation really is going to be delivered. I think if we go back to our case, so this is back to our case that we started with, so that 66-year-old lady with colon cancer, with T12 pathologic fracture, epidural disease. She actually underwent surgery at an outside facility and presented to me thereafter. And you can see this was the surgery that she had done, had done. And so patient had a midline dorsal decompression, really no ventral separation, no ventral tumor debulking. No pedicles were drilled off, no facet was taken down, and so really this is not separation surgery. This, I would argue, this is a dorsal laminectomy for tumor biopsy, essentially. And I think, this is, I think, what we need to get away from, knowing that this led to a recurrent surgery, another hospitalization, and really push down the ability to deliver effective radiation and systemic therapy in an effective time window. This is a nice illustration of what separation surgery is. So the way we do it, typically we put our instrumentation first. We do a dorsal approach laminectomy with bilateral fascectomy. Typically, we try to find a focal area where we can isolate a pedicle, take down both pedicles or one, depending on what the patient needs. We do end up taking the nerve root if it is in the thoracic spine, and we're able to take it safely. And then ultimately, we finish by using Whitson elevator and down-pitching curettes to really make sure that we've got nice ventral separation. Really, the key to this operation is the posterior longitudinal ligament, or the PLL. And so this is a nice picture, I think, that demonstrates that. You can see how when the epidural tumor causes compression to the spinal cord, it forms almost like a triangular curtain-like fashion. And what really serves as that barrier is the PLL. The PLL is, it's attached around the disc space, attached to dorsal body, and ultimately that's what prevents or provides the barrier for epidural tumor invading into the dura, or you could say coming to the other side of PLL. And oftentimes when you do these cases, the PLL is always preserved. It's just a matter of being able to identify or dissect it free from the actual dura. Oftentimes, and this is a nice illustration, nice schematic demonstrating that, but I think if you can see the PLL, identify it, coagulate it, and really cut it sharply, ideally perpendicular so it's completely free ventrally, I think for me that really confirms that we've got adequate decompression. It also allows, you can see on your post-op MRI, some amount of CSF egress or kind of the cord to drift back, so to speak. We do use intraoperative adjuncts, kind of one plug to ultrasounds. I didn't use ultrasound at all in my training, and actually in fellowship we used it almost for every case, and now I use it for almost every case. Really, there's no imaging modality that I think provides the same dynamic feedback, especially metastatic disease, where you don't really have the luxury to go back and take more out. So that adds delays to their care. And so this is a nice schematic of the thoracic spine and a nice one for the lumbar spine, really using this to confirm that we've got good decompression. And this is our goal. So patients with high-grade compression, we hope on a post-op CT myelogram, we've got good circumferential decompression with CSF signal like this. And here's a correlative MRI as well. So nice decompression. You can see here, you can see the cord nicely with a nice border around it for radiation contouring. We've got kind of two cases to kind of go through. One is, we'll start with the first one, but it's a case basically of a patient with multifocal disease. And so this is a 63-year-old woman with metastatic renal cell carcinoma, oligometastatic. So less 1 to 5 sites. She came with back pain, thoracic radiculopathy, really with no history of radiation of the spine. She was diagnosed in 2015 and it's fairly high functioning, good strength, just a lot of back pain, both mechanical but also radiculopathy. And this was her pre-op scans. And so really she had 3 focal areas in her spine that had disease. So T6, T9, but also L1. And you can see here at T6, there's quite a bit of lytic destruction. T9 has a little bit kind of in the lamina pedicle junction. And L1, really, it's the entire posterior elements are involved. And so what do we do? So, again, we went back to our conversation. We talked to our radiation oncologist, and really we were trying to determine, what are our options here? Is there, do we just do surgery for T6 and then radiate everything else? Do we state that, things are kind of close and, maybe you should just radiate everything with conventional radiation, even though we know that this is a radio-resistant tumor that probably won't respond to that? And so ultimately, after our many discussions, the final plan was, we were going to embolize all 3 sites. So we have some early data that we published last year from our group looking at perhaps some evidence that levels of embolization may improve local tumor control after radiation. So we embolize all 3 sites, and then we plan for a corpectomy at T6 with a short segment fixation. And then because of the dosing strategy, we also went after the right T9 lesion because it arguably is in our radiation field. Or arguably was in our surgical field, sorry. So we ended up debulking and taking that out as well. So here are post-op films. And so you can see here, so we did basically a right-sided transpedicular decompression corpectomy approach with a right lateral extracavitary. We left, you can see here on the left side, on the CT scan, we left the left side of pedicles, the left side of facet joints all intact. And really, you can see on the coronal view that the cage is eccentric to the right side. And really, this is something that I've continued to adopt more and more when looking at cases that need anterior column reconstruction. Is this idea of, you can say, a hemicorpectomy, but really tailoring your separation surgery to where the defect is, and really encouraging leaving normal bony elements as long as they're not compromising your ability to get adequate separation. And so given that we left, a unilateral approach with cement augmentation, we did do a short segment fixation here. So as mentioned, hemicorpectomy with cage placement, short segment fixation, and really tailoring that decision-making. She's about 8 months out now, and she's doing well. Hardware is still intact, and still, back on treatment after completing her radiation. To contrast that, so this is a case of patient with diffuse osseous disease. And these are, I would say, significant challenges, mainly because we always wonder about what is fixation and what is too much for this patient population. This is a patient with 76-year-old female with metastatic breast cancer, ER positive, HER2 negative, PR negative. And so she had some hormone receptor status that was positive. She came in basically with 3 weeks of severe mechanical back pain, radiating across the T6 dermatome. By the time she came in, she was kyphotic in posture. She was really shuffling her gait and was hyperflexic in her lowers. This was her scan. So you can see here, you have on the CT scan, really diffuse osseous metastatic lesions, numerous lytic lesions with T5-6 subluxation. And again, you can see on the MRI, really riddled with disease, but also high-grade epidural compression at T5. High-grade SINs, high-grade compression. A lot of dilemmas here in terms of what to do. Do you address the focal level? Do you consider going, palliative because you were a fixation and durability of fixation? I think being breast primary, she is radiosensitive, so really a lot of conversation, a lot of difficulty in figuring out what the right thing to do is. Ultimately, we decided to offer her surgery, given that it was a breast primary. We talked to our medical oncologist. There was good sentiment that she was going to have good durable response with chemo. We were able to reduce her subluxation at T5/6, so we did a full T5 corpectomy. We did put a cage. We went a little bit longer, mainly for fixation reasons. We went 3 above, 3 below, used cement augmentation. And really, I think that's also something that's helped me go shorter when I want to, is to use cement augmentation. And here you can see her post-op MRI. So we got really adequate separation, nice, diameter of the cord. She ended up getting conventional radiation, and she's done well. She's a year out now. So this is her post-op MRI, her post-op standing scoliosis X-rays. I did put her in a brace, just given her bone quality and the amount of lytic lesions she had. This was her 1-year post-op X-ray, and she's doing well. Her pain is well controlled. She's kind of back to doing the things she likes to do. And really, I think really when it comes to patients with multifocal and diffuse osseous disease, I wouldn't say surgery is a no, but I think we have to be very thoughtful in terms of what is effective and what's too much. In terms of the data, so separation surgery with SRS, so this is a series out of MSK in 2013, looking at 186 patients. Patients received post-op single fraction dose, high dose hyperfractionated, or low dose hyperfractionated. There was good overall durable response, so about 84% local control, with no association of radio-resistant tumor histologies, previous radiation, nor epidural extension. And so, as mentioned, I think it's across the board. I think this works. We've seen it in different studies. So here's a case series about renal cell carcinoma, so 90 patients with good local control. And ultimately, I think we really want to go back to the emphasis that it's not so much does it respond to radiation, it's more so can we deliver ablative therapy, and how as surgeons can we facilitate that process. And I think the more we're thinking in that way, the more we can find opportunities to help these patients. And here's the Kaplan-Meier curve on survival. We look at colorectal carcinoma, similarly 50 patients with 87% local control at 2 years. Again, adding in some mutational factors. So patients with APC mutations may have worse prognosis when they have spine mets. And then lastly, in non-small cell lung cancer, so 103 patients giving 95% local control at 2 years. And so I would say, does it work? Absolutely. I think in summary, you can say patients with radio-resistant tumors, spinal cord compression, really those are the ones that benefit from separation surgery and SRS. And so I think continuing to understand that, I think this is durable, it's valuable, and how we evolved. And so I think separation surgery has taken a great evolution. We've gone from doing long segment fixation, multi-level corpectomies, to really going now towards more short segment fixation. We know in the long construct literature, there was greater risk when patients were instrumented more than 6 levels, were instrumented across the junctional spine, or were postmenopausal. And so that's transitioned us to really go to the short segment model. So short segments, so 1 above, 1 below, using cement augmentation for good fixation and good durable fixation strategies. I think there are some concerns that can occur at the thoracolumbar junction, but I would say largely with good anterior column support, this provides a good durable construct that can get them through radiation and be durable thereafter. We're able to incorporate MIS techniques, so using tubular retractors, percutaneous screws, different ways to have a smaller footprint so patients can get to radiation safely with less wound-related complications. And we know the patients like it. So when we look at the PROs, there's improvement in pain interference, patient experience, but also symptom interference as well. So again, as much as we're appreciating doing more minimally invasive approaches, so are patients. So here we notice there's a monkey riding a tricycle. So kind of give everybody a moment to catch their breath before we come to the finish here. So I really want to close with this idea that I want to leave you with the idea that I think as spine surgeons, I want to encourage you all to get involved in oncologic care. I think we get involved in various ways, and obviously as surgeons, we put in hardware, we do the surgery, but I think there's way more involvement and way more benefit to our patients we provide just by getting more involved. Um, find ways to establish some sort of multidisciplinary tumor boards or conversations. Find your key leaders or key individuals at your own institutions who can be those champions, who can kind of work to have these discussions. I think it's very helpful to conduct spine SBRT contour reviews. I think as neurosurgeons and spine surgeons alike, we kind of lose the perspective of what are the challenges radiation oncologists undergo, and what ways can we make it easier for them. Ultimately, when the patient recurs and radiation doesn't work as effectively, it comes back to us anyway. And so I think the better we can kind of understand that paradigm, that relationship, I think the more we can be aggressive earlier if we need to be. And again, I think it comes back to collaboration. And I think ultimately, when we don't know what to do, we have to ask our partners in these efforts to help us get there. And our goal is really to bring these three paradigms, the surgery, targeted therapy, and radiation together. And the more we can do that, I think the better it is for our patients. We do it through multidisciplinary tumor boards and tumor programs. So things like neurosurgery, orthopedics, radiation oncology, medical oncology, rehab. And the more we can kind of circle everybody together, I think the better we're able to take care of our patients. With that, I want to close and happy to open the floor to questions, comments, and discussion.
Awesome. Fantastic talk. That's really interesting, and oncology care in the spine has come a long ways. I have a couple kind of basic questions. One would be, the thing I struggle with a lot in like deformity surgery is we're always trying to come up with frailty indexes that kind of quantify like who's going to do well and who's not going to do well with surgery. But there's something to be said about just like laying eyes on the patient, and there's just that sense you get from meeting the patient, talking with them deep down inside. How does that influence your decision on who's a good surgical candidate, or do you really rely on these indexes, or is it more of a just talking to the patient, seeing do you think they're going to be a good candidate or not?
Yeah, I think it's an ongoing challenge, and I think it's definitely a combination of all of that. I think you have to see the patient. I think a lot of knowing what their family support is, knowing what their preoperative status is, knowing what their motivation is. In addition to frailty, I think it's important to know what other options do they have available. Is this the third line therapy, fourth line therapy? Is this a new diagnosis? I think a lot of that plays into if it's not. I think frailty is very important. It's just I think it's one piece of that bigger puzzle.
Yeah. My other question is, I know that you've been using quite a bit of the carbon fiber screws recently. What are the advantages and disadvantages of carbon fiber screws versus titanium or other materials?
Yeah, so we kind of transitioned really on the oncologic space fully to carbon fiber a couple years ago. I think definitely some advantages are, we're able to see local recurrence better. We're able to use perfusion MRI to evaluate for actual treatment effect. I think some of the challenges, and then the third benefit I would say is it really helps our radiation oncologists. You'll notice on those screws there's a small tantalum marker, and so that allows as another co-localizing point for when they plan the radiation. And just being able to see and contour the spinal cord more effectively, I think it allows us to be more aggressive with delivering ablative therapy. So less of conventional radiation and more of targeted SRS. I think the challenges which we're continuing to kind of work through are, one is when we do see hardware failure, it's sometimes hard to see, both between X-ray but also CT. And so if you're reliant on other factors, things like alignment of the pedicles, alignment of the adjacent instrumentation. So that's the biggest thing. I think with cement, definitely helps the durability. I would say arguably in terms of how it feels and the bite, there's maybe a little bit more. With titanium, we really just put screws in with minimal tapping, with definitely carbon fiber because it's not as aggressive. You have to tap the screw nearly to the entire depth. But I think overall it's been a good experience and a good transition, but we're definitely learning more and more about its value.
Awesome. Thank you. Any other questions about anything?
Yeah, no, Vikram, that was great. Really nice overview. You know, we struggle with this a lot. Just yesterday, we kind of looked in our case conference at a spine on case, and I think you're absolutely right. You've got to have a systematic way of looking at it to see how you can help the patient, and of course, kind of invoke a multidisciplinary panel, if you will. But I'll tell you, despite all of the, and I think you would agree with this, despite all of, you know, the NOMS and the SINs and everything else, every patient is different. Like literally every patient is different. The same age, the same primary tumor, you know, it just depends, right? And somebody said, you know, do they pass the eyeball test, right? You look at the patient right away, you get a sense whether you should really kind of do surgery or not. How do you handle that in your practice, where you do go through you know, systematically the scores and the classification systems, but at the end of the day, I feel like it still comes down to that individual patient, you know, what's their, you know, functional kind of status, how old they are, and whether they can tolerate any surgery or not. You know, because you talk to the oncologist, they're always going to say the patient has, like, you know, more than a year to live, but the reality is we know they don't. So can you kind of share some thoughts on that?
Yeah, I think so. I would categorize presentation into like 3 categories. So one is, you know, spinal cord compression with neurologic weakness. 2 is mechanical instability, like gross mechanical instability. And then the other category is just, you can say, you know, epidural compression, whether it's lumbar disease or just bony lesions. And certainly, when it comes to spinal cord compression and like gross mechanical instability, to some degree, I would argue I'm more aggressive, because I think if there's good support from med-onc, rad-onc, knowing that there's next lines of therapy, in some ways, I think it's better the patients don't die paralyzed or, you know, don't deal with bowel bladder issues. And if there is good, favorable, you know, let's say shared sentiment that, you know, patients are going to live at least a month, at least 3 months, then I think then I'm more willing to offer surgery. I think in those situations, you know, to your point, it's, you know, as a surgeon, we have to offer it. I don't think it's, you know, they have to go through surgery. You know, these are complex decision-making standpoints. The latter group, you know, when patients come in with just epidural disease and, you know, maybe they are, you know, much worse off, poor frailty, numerous lines of therapy, then it really becomes a conversation and knowing that, you know, let them get the conservative approach, you know, radiation, chemotherapy, but follow them closely. You know, have them, you know, get a short interval MRI, maybe at, you know, in 6 weeks or 2 months. I follow all these patients when they leave the hospital, so I don't necessarily rely on just the medical oncologist to see them. And so I think that allows me to kind of keep tabs in terms of, are they getting worse, are they not getting worse, and really tailor that decision making as they evolve.
Yeah, thank you for that. No, that's a good way of putting it. I can tell you where, you know, I used to practice in you know, across the street from Memorial Sloan Kettering with Dr. Bilski and Ilya at that time, who was there. And, you know, I think to your point, it's, if you're going to do cancer surgery, spine surgery, if you're going to do metastatic spine surgery, I mean, there's no way about it. I like what you said. You said I'm a little aggressive, and you're honest about that, because you're right. You have to be aggressive. Otherwise, 99% of the patients you can argue for not having surgery, right? I mean, for a lot of patients, you can say, well, they're sick, or they have systemic disease, or they have stage 4 cancer. So at some point, you know, and they kind of basically told me this. They said, listen, we're at a cancer center, like that's what we do, right? Whereas I think in a lot of the community-based hospitals, that's probably not the standard to do a lot of these surgeries, right? Separation surgery and fusion on patients in their 70s, 80s sometimes. But there's no question we can't push the field forward. We can't learn more about this. We can't help patients unless folks, especially in the academic circles like yourself, really push that envelope. So, you know, I would just say that for the young folks on who will hear this or are seeing this live, it's, you have to take it into the correct clinical context, as well as the almost the infrastructure that you have around you. Not every hospital, not every medical center is positioned to do some of these surgeries and take on some of those patients. So you have to understand your environment. Otherwise, you can easily kind of get in trouble with some of your peers and anesthesia and everybody else. You know what I'm saying, right, Vikram?
Yeah, and I would agree. And I would add to that. I think as you know, our surgical techniques have evolved. I think the more thoughtful you can be with these patients, really, it's pushing yourself to be smaller, shorter segment. MIS approaches. I think it allows us to help more patients. We're not doing long constructs that have high morbidity. These are short segments. 3 segments of instrumentation. They're out of the hospital in 5 days. They're up and moving the next day. Really, I would argue an oncologic patient has to be treated like our great degenerative deformity patients. They're on the same ERAS fast track out, and they get treated the same way.
Thank you.
Yeah, awesome. Thank you. Awesome talk. Any final questions from anyone? Doesn't look like it. Well, Dr. Chakravarthy, thank you so much. Thank you, everyone, and yeah, everyone have a good rest of your day.
Thanks, guys. Thanks.